Go here. So just a reminder, these are the 3 virtual summer series dates, and you can register for our last session, which is going to be on Wednesday, August 25th at 6:30 p.m. And you can register at bjc.org. So hope you can join us for that last session. Now let's get started. So our Champions for Care Committee of Missouri Baptist Medical Healthcare Foundation is excited to present after a breast cancer diagnosis. Champions for Care are donors who support special projects focused on improving care for our patients. Now, many of us are aware that 1 in 8 women will be diagnosed with breast cancer in their lifetime, but many of us are not aware that 3/4 of women diagnosed with breast cancer have no family history and don't think that they're at high risk. Now, tonight we have a panel of experts who will help us understand why we need to create a culture of annual screenings, timely follow-up, promote genetic testing to reduce the risk of breast cancer for our friends and our family. Now, this is just a quick picture that shows all the various locations for men and women to get screened and follow up with highly recognized experts on an annual basis. But first up, I do want to introduce our first speaker. Dr. Melissa Rooney is a medical oncologist, hematologist at Missouri Baptist Medical Center. She has been practicing hematology and medical oncology in the St. Louis area since 2014 and has been at Missouri Baptist Medical Center since 2019. Dr. Rooney sees adults with blood disorders and cancers of all subtypes, with a special interest in breast cancer prevention, cancer genetics, and breast cancer treatment. Dr. Rooney, we would love for you to share your findings on breast cancer, genetics, and risk factors. Dr. Rooney.
Thank you for having me. Do you mind just advancing the slide on to the next one? Okay, so when I meet with my patients when they're first diagnosed with breast cancer, one of the first things that I tell them is that although breast cancer is lumped together as one disease, it's really many diseases. And what I mean by that is not any one breast cancer behaves the same. So breast cancers can have different degrees of aggressiveness. Some have a greater tendency to spread beyond the breast, and they have different responses to the different treatments that we have available. So when a woman's first diagnosed with breast cancer, oftentimes they've had a biopsy by the time they've come to my office, and I get a description from the pathologist with respect to where the cell may have started in the breast. So the most common descriptors we get are that the cancers are lobular cancers. So they started in the lobules of the breast where the milk is made, or they're ductal cancers. They started in the milk ducts. And for all intents and purposes, these are typically treated the same. So this is really just a descriptor that they use. So if you want to move on to the next slide. Okay, so kind of the next thing that we'll do is we move on to staging the cancer. And there are several staging systems that are utilized, but most commonly we use the pathologic staging system. So this is typically the staging system that we're able to use once a patient has undergone surgery, and we're able to look at the mass under the microscope and get an accurate size and look at the lymph node status. The clinical staging is oftentimes derived when a woman's first diagnosed and maybe she hasn't had surgery yet. So then we're using like radiologic imaging and her physical exam to determine that staging. So both staging systems utilize something called the TNM classification system. So the T is the tumor size, the N is the lymph node status, and M is metastatic disease. So whether or not there's concern for disease spread. And typically through the TNM classification system, we can at least come up with an initial stage of 0 to 4. So 0 would be in situ disease, where the cancer cells are either lining the lobules or the milk ducts, and they have not yet invaded into the normal healthy breast tissue. once you have an invasive cancer, we know that it's gotten out into other areas of the breast. So after that initial staging, there's a lot of other information that I take away from the pathology report, not only to help me get a better understanding of the biology of the tumor and how I expect it to behave, but also to come up with a treatment. So one thing that the pathologist will tell us is the grade of the tumor, and they'll grade it 1 to 3. So grade 1 is that the cells look a little unusual, so they're low grade, and grade 3 is that they're more aggressive, so they have a more bizarre appearance to them. So if you want to move on to the next slide, please. So on that initial biopsy, we also obtain information that's really important in treatment planning. So the pathologist is able to tell us whether or not the breast cancer expresses the estrogen receptor or the progesterone receptor. And if either or both of those are positive, that tells us that the tumor's feeding on estrogen for growth and survival. The third piece of information they'll give us is whether or not the tumor is expressing a protein on the cell surface called HER2. So HER2 is turned on or overexpressed in about 1 out of 4 to 5 breast cancers, and historically has been associated with a more aggressive breast cancer. So we use these 3 bits of information to help identify what type of treatment we're going to offer. If all of the estrogen receptor, progesterone receptor, and the HER2 are negative, that's what we call a triple negative breast cancer. If they're all positive, that's a triple positive. So you can go ahead and move on to the next one. Okay, so most women, when they're first faced with their diagnosis of breast cancer, they usually come into contact with 3 physicians. So they'll see their surgical oncologist, their medical oncologist, and then also their radiation oncologist. And so I'm going to focus on the medical oncology aspect since that's what I do. So we can move on to the next one. Okay, so as a medical oncologist, I give systemic therapies. So these are treatments that not only target the breast, but they go throughout your entire body to try to kill the cancer cells. So one of the most important decisions that I have to make when I first meet a woman is whether or not I think it's most appropriate for her to have neoadjuvant therapy. So that means systemic treatments before surgery, or adjuvant therapy, so treatment after surgery. Some women will require both. There are certain circumstances where we'll consider giving systemic therapy up front. There are certain advantages and disadvantages. But I would say if I focus on the advantages, when you get treatment ahead of time, it oftentimes affords a woman to have a smaller surgery in the future. We also can see whether or not a woman is actually responding to the treatment, and that can be assessed at the time of surgery or on clinical examination. Also, as I kind of pointed out before, the therapies I give go throughout your entire body. So if we're able to give the therapy ahead of time, we may be able to kill some of those cancer cells that escaped the breast and kill them before they decide to set up shop somewhere and start growing, if they're circulating in the lymphatic system or the bloodstream. So I guess we can go on to the next slide. So in terms of systemic therapy, there's really 3 flavors in breast cancer. So we typically will talk about chemotherapy, HER2-directed therapy, and endocrine therapy. So chemotherapy is utilized most commonly in women that have triple negative breast cancers. So those are the cancers that do not express hormones. And chemotherapy works to non-selectively kill cancer cells. So there's not really a target per se that they're going after. HER2-directed therapy, which my next slide will touch on a little bit. These are therapies that specifically work to downregulate or turn off that protein in women that are overexpressing HER2. For women that have HER2 positive disease, they oftentimes will get HER2-directed therapies in combination with chemotherapy. And then lastly, we have endocrine therapy. So endocrine therapy, these are therapies, again, that reduce feeding estrogen to the cancer cells. So women that have HER2 positive disease can also have hormone receptor positive disease. So they may be a candidate for all 3 of these treatments. For women that have Triple negative, again, just chemotherapy for the most part. And then women that have hormone receptor positive but HER2 negative disease, they oftentimes will only get anti-estrogen therapy. And then there are certain circumstances where they may receive chemotherapy. So you want to move on to the next. Okay, so again, this is just touching on the HER2 signaling pathway. So HER2 is a protein that is typically expressed on the surface of breast cells. We do have certain cutoffs that the pathologists use when they determine if a woman is making too much HER2. So if there's too much HER2 protein being expressed on the cancer cells, the cells grow uncontrollably and they divide very quickly. And so we now have therapies that bind to this receptor, these small proteins on the surface of the cancer cell, to try to downregulate those proteins, and that can dramatically improve a woman's outcome. Can go on to the next one. Okay, so briefly, endocrine therapy. These are these anti-estrogen therapies I was talking about. So another important thing that we have to make a determination about early on is whether or not a woman is pre or postmenopausal. So if a woman's premenopausal, we know that they are still making estrogen from their ovaries. Once you're postmenopausal, the ovaries shut off and you're no longer producing estrogens in the ovaries. And so there are a couple strategies to downregulate estrogen in the breast cells. So on the left-hand side, we have a medication called tamoxifen. So in the breast cells, there are these estrogen receptors in about 80% of all breast cancers. And estrogen is binding to these receptors and they're feeding on that estrogen. So there's a medication called tamoxifen. Tamoxifen binds to the estrogen receptor and stops all estrogen that's being produced in the body from binding to the estrogen receptor. And as a result, the cell starves and dies. So the two main sources of estrogen, again, in a premenopausal woman are going to be the ovaries and then also the fat cells. So then on the right-hand side, we have the second class of medications. So these are the aromatase inhibitors. The way these medications work is that they actually shut off estrogen production predominantly in the fat cells. So in your fat cells, you have androgens, and these get converted into estrogen by an enzyme called aromatase. So these medications shut the enzyme off so you no longer produce estrogen. These medications are only effective in postmenopausal women because they're only shutting off the estrogen coming from the fat cells. They do nothing to shut off the estrogen that's coming from the ovaries. So if we want to consider aromatase inhibitors for our premenopausal women, which there are some cases we'll do that, then we have to shut her ovaries off with medications or have them removed. And go on to the next one. Okay. So just briefly, we're moving and breast cancer treatments are evolving greatly, particularly in the field of estrogen receptor positive breast cancers. There have been a lot of advancements over the years. We now know that not everyone estrogen receptor positive breast cancer behaves the same. So beyond just knowing the grade of the tumor, the size of the tumor, we also know that there are certain genes that are turned on or turned off in the cancer cell. And they provide not only prognostic information based on their levels of expression, but also predictive information. So whether or not a woman's even going to benefit from getting chemotherapy. So for a good majority of our patients that have hormone receptor positive breast cancers, we send off gene profiling testing. So a few examples are Oncotype, MammaPrint, and Prosigna. So these are tests that are actually run on tumors. Once they've been removed from the breast, they get sent off to a specialized lab, and they help us in determining a prognosis for our patients, as well as a predictive benefit of chemotherapy. And we use these results to make our treatment decisions for women that have hormone receptor positive, HER2 negative breast cancers. So we can move on to the next slide. Okay, then my last two slides, I just wanted to make a couple of plugs. So at Missouri Baptist, we do have a very robust clinical trials program. Many of our breast cancer patients are eligible for our studies that we have, so we always encourage our patients to enroll, and we are continuously screening them to see if they meet the criteria for clinical trial, and we offer these trials completely voluntary, whether or not our patients decide to participate, but we do have a wonderful program at Missouri Baptist, and there is a website where patients can go on and kind of browse what trials are available. And then the last plug is for our cancer genetics program. So we are blessed to have 2 cancer genetic counselors, and we are able to offer their services to our patients. And so it's really important. Cancer genetics is becoming kind of the way of the future. We know now in breast cancer that probably about 5 to 10% of women that are diagnosed with breast cancer, they do have a hereditary predisposition to the development of breast cancer. So in their germline, so the DNA they were born with, they may have a mutation like a BRCA1 or BRCA2 mutation, and that's a susceptibility gene that they're going to be at very high risk for developing breast cancer over their lifetime. We also know that there's familial clustering of cancer. So these are patients who have germline testing done, but a mutation is not identified, but it seems to run in the family. So it may be something environmental. And then about 80% of these are going to be sporadic cancers where we don't really have an explanation for why a woman goes on to develop breast cancer. So we are now starting to incorporate a lot of this information into surgical planning, and now even in some of our systemic treatment options. So we're very lucky to have them. So that's all I have for medical oncology.
Well, thank you, Dr. Rooney. We're lucky to have you. So our next speaker is also recognized as an expert in his field, Dr. Paul Yazdi. He is a breast surgeon at Missouri Baptist Medical Center. Dr. Yazdi focuses his practice on both cancerous and non-cancerous diseases of the breast. He has completed a surgical oncology fellowship and is recognized as a breast surgical oncologist. And he is also recognized on the Best Doctors of America's list. Dr. Yazdi, please share your findings on various surgical techniques based on a specific diagnosis of breast cancer.
Thank you. I appreciate your having me. And Melissa, you did a great job. I enjoyed that. And as sometimes I think I know a lot, but I learned a lot. So I appreciate that. The vast majority of patients who are diagnosed with breast cancer will have surgery to remove the cancer from their breast. And in fact, in general, there is not a real good cure of breast cancer that does not involve surgery to remove the cancer. As Dr. Rooney mentioned, probably about 2/3 of the patients we see will go for what we call upfront surgery. They will have surgery first, followed by the rest of their treatments afterwards. And probably about 1/3 of patients will receive some type of hormonal or chemotherapy treatment and then surgery after that. But most of them will eventually have surgery. In general, there are 2 operations we can do for breast cancer. And the purpose of the surgery is to remove the cancer, and plus we want to remove a rim or margin of tissue around it. So the first operation we can do is called a lumpectomy. A lumpectomy involves a cut or incision in the breast in the vicinity of the cancer, and then you go down to the cancer and we remove the cancer plus a rim or margin of tissue around it. Can I have the next slide, please? The other operation that we do is a mastectomy to remove the cancer. And a mastectomy involves removal of the entire breast itself. So those are the 2 basic operations that we do for breast cancer. In general, there is no survival difference between the 2. The chances of you living the rest of your normal, natural life is equal with lumpectomy versus mastectomy. There's a slight difference in what's called local recurrence rate. Now, local recurrence is the chances of it coming back in the remaining breast tissue. With a lumpectomy, we purposefully leave more breast tissue behind, and the local recurrence rate's slightly higher. With mastectomy, we take out more breast tissue, so we have a lower local recurrence rate. Roughly, the local recurrence rate after mastectomy is 2 to 3% versus 6 to 8% with lumpectomy. So there's a slight difference in local recurrence rate, but no difference in long-term survival rates. For the most part, they're thought to be equivalent operations because of the only slight difference in long-term recurrence rates. In the modern age, our preference is to do lumpectomies when we can and sort of mastectomies when we have to. Lumpectomies are smaller operations, less traumatic, cosmetically superior. And so that's generally speaking the operation we're looking to do unless we have to do mastectomy. And at Missouri Baptist, we tend to do close to 70% lumpectomy, about 30% mastectomy. We look at three things to determine can you have a lumpectomy. Number one, we look at how many areas of cancer are there. If you have a single area of cancer, like quite honestly the majority of patients do, that's good for lumpectomy. If you have multiple areas of breast cancer, then the tendency is to need to do a mastectomy. So that's the first thing we look at. The second thing we look at is how big is the area that we have to remove. Large advanced breast cancers, sometimes by the time you remove the cancer and you remove a margin or rim around it, it can be most of the breast or half of the breast. And so sometimes if you have a larger advanced breast cancer, we'll recommend a mastectomy. If you have a relatively small breast cancer, then we can do lumpectomy. Those are probably the two most important things we look at, and we determine those by mammography, ultrasound, physical examination, and every once in a while we'll get an MRI on the patient to help us determine that. The third thing we look at is something that Melissa mentioned earlier. Nowadays, every woman diagnosed with breast cancer gets a genetic test. It's pretty much an automatic nowadays. And so if you test positive for one of the breast cancer genes, then there's probably more of a tendency to recommend mastectomy. And the reason for that is if you test positive for one of the breast cancer genes, you have a higher chance of getting a second breast cancer. So for example, we might be able to cure this breast cancer, but then 5 years later, another one pops up. And then 5 years later, another one pops up. That kind of thing happens more frequently if you're a genetic carrier or if you got breast cancer because of a gene. And in fact, with some of the genes, the BRCA1 and 2 genes, you have up to a 60% chance of a second breast cancer. And so even if you're a candidate for lumpectomy, we might want you to consider mastectomy or double mastectomy in those instances. So that's kind of the first basics that we go through is, can you have a lumpectomy? Do you need a mastectomy? And then we usually talk to the patients about that. May I have the next slide, please? There are pros and cons to each technique. Probably the pros to the lumpectomy are a more natural look to your breast, less numbness. When you have a mastectomy, for the most part, you're numb across the chest after a mastectomy. Even if we do what's called the nipple sparing mastectomy, you do lose sensation of the nipple and the chest, so there's less numbness. And most commonly what people appreciate is the quicker healing time after surgery. Lumpectomy is an outpatient procedure. You are able to go home the same day. And most people recuperate at home nicely after about 2 weeks. And it is a less difficult recuperation. There are no drain tubes for the most part. And it's just kind of resting and relaxing at home. There are some cons to a lumpectomy, even though it's a more natural look to the breast. Sometimes the shape of the breast doesn't match. You can get a smaller size on the side we do the surgery. At times you can get dimpling, and it doesn't quite look the same as the opposite side. You are more likely to need radiation after lumpectomy. You are less likely to need it after mastectomy. And probably the one that's perhaps most significant is lumpectomy may not remove all the cancer cells, and we sometimes have to do a second operation. At the time of lumpectomy, we can remove everything that looks bad on the mammogram, everything looks bad on ultrasound, everything that to my eye and to my field looks bad. But unfortunately, you can have small cancer cells that kind of stream off from the tumor. And the only way to know for sure that you've got it all out is to get a pathology report with a pathologist look at it under the microscope. And so the patient comes, has the mastectomy, they go home, and after the pathologist looks at it for 4 or 5 days, we get a report, and there is a percentage of patients that need to go back to the operating room to have some microscopic cells removed. We do track that number, and it's about 15% of patients that require a second operation to remove more tissue. And there's currently no way to get around that. Until they develop new technology where my glasses can be microscopic or something, there's just no way to fix that right now. So that's just what we have to deal with. Now, mastectomy has some pros as well. So for example, If a woman either wants or needs a mastectomy, we can do reconstructive surgery. That reconstructive surgery can be done at the same time as the mastectomy. We do what's called immediate reconstruction, or it can be done in a delayed fashion. And in that instance, you would have your mastectomy, finish your cancer treatment, and then you would get reconstruction done down the road, perhaps 6 months or a year later. But we do work with plastic surgeons all the time to do mastectomies with reconstructive surgery, and that works just fine. You are less likely to need radiation with mastectomy, although it's not a guarantee. There are some instances, which Dr. Joe can explain better than I can, where you would need post-mastectomy radiation. And for some women, it just feels more comfortable to them. Although it's no better than a lumpectomy, some women worry less about recurrence. They don't have to have a mammogram again, and they just feel more comfortable with it. And unless there's a medical reason not to do it, for example, if you're elderly and you're unhealthy, perhaps doing a bigger operation doesn't make sense. But other than that, we do accommodate those desires. There are cons to the mastectomy as well. The biggest one is the loss of the breast itself, and then the significantly longer healing time. A mastectomy, most patients come in, they're in the hospital overnight, and they go home the next day. And then we tell most patients that the healing time after a mastectomy is approximately 6 weeks compared to the outpatient 2-week healing time of a lumpectomy. And that 6 weeks of healing can be more significant. You would have drain tubes, and you are more confined to your home. There's a period of time where you will need help with activities of daily living, such as bathing, cleaning, cooking, and stuff. So it's a little bit more of a big operation. And going along with the bigger operation, there are more side effects. We have slightly higher rates of infection and bleeding and pain and discomfort and scarring associated with the bigger operation of the mastectomy compared to the lumpectomy. All right, next slide, please. So the main part of our surgery that we do is to get the cancer out of the breast. And that can be lumpectomy or mastectomy based upon the 3 factors that we talked about, and then also based upon the desire of the patient. The second thing we want to do is we want to make sure that there's been no spread to the lymph nodes. And the lymph nodes we're talking about primarily are the lymph nodes in the axilla or the armpit, usually on the side of the cancer. So if it's a left-sided breast cancer, we're worried about spread to the left armpit. If it's a right-sided breast cancer, we're worried about spread to the lymph nodes in the right armpit. Now, we do testing prior to operating on the patient to determine if there's any enlarged lymph nodes. For example, most patients will have an ultrasound of their lymph nodes. We'll examine them. And so we have a pretty good idea going in if there's any real abnormal looking lymph nodes. And if there are abnormal looking lymph nodes, we will actually do biopsies on them by needle before we do treatment or surgery to know if they have cancer in it. The problem is that even a completely normal looking lymph node could have some microscopic cancer in it. And there's no way to know for sure that they're not involved, short of removing a lymph node and taking it out and making sure it's okay. So part of the surgery we do is to sample the lymph nodes and make sure they're okay. The majority of the patients who come in to see us and they have no evidence of spread to the lymph nodes, and by that I mean no big lymph nodes or anything, we'll do what's called a sentinel lymph node dissection on. And so what that is that if the cancer was to spread through the lymph nodes, it's typically found in one lymph node called the sentinel lymph node. And we have the ability to inject dye in the breast, typically the day before, and that dye travels through the lymphatic pathway of the breast and then is deposited in that first lymph node. And then in the operating room, we have the ability to go down to where the lymph nodes are in the armpit and then find that lymph node that has the dye in it, which is called the sentinel lymph node, and then remove it and have it analyzed to make sure there's no cancer. So it's very common to do a sentinel lymph node biopsy and removal as part of our cancer surgery. Were there questions there? I'm sorry, I thought I heard something. Sorry. Now, if the patient comes in and we can tell that they have cancer in the lymph nodes beforehand, for example, they have enlarged lymph nodes by ultrasound or a physical examination, then we tend to need to do a more aggressive lymph node removal. And so we would do what's called an axillary lymph node dissection. And in that instance, more lymph nodes are removed in the armpit, and it can be anywhere from 10 to 20 lymph nodes that can be removed in that operation. That operation is fine if you have cancer in the lymph nodes and you have to get it more aggressive to get those lymph nodes out. But quite honestly, it has a higher rate of complication. Many people are familiar with patients in the old days that would get swelling of their arm after lymph node surgery, or what's called lymphedema. The rate of that lymphedema is most associated with the full lymph node removal, and that rate can be up to 25% of women who have that surgery. Sentinel lymph node was specifically designed to decrease the rate of lymphedema, and patients who undergo sentinel lymph node removal have a less than 5% rate of lymphedema. So that's why we try to do that operation when we can, and then we do the full lymph node dissection kind of when we have to. Next slide. That's it for me. So one last thing before we go to Dr. Joe I wanted to mention is reconstructive surgery, just in a little more detail. When we do lumpectomies, we typically recommend no reconstruction be done. We do the surgery, and then the patient receives any treatments they need afterwards. The vast majority of patients are satisfied with their cosmetic outcome, and they feel like there's no need for reconstruction. If they have a small change to their breast, in clothing and bra, it looks okay. And I would say over 90% of our patients who undergo lumpectomy don't want or require reconstruction. In the patients who do have a difference in size, we send them for reconstructive surgery about a year later after everything's settled down, and they can get surgery done to get them to match. As I mentioned, when we do mastectomies, we will many times do reconstructive surgery in conjunction with the mastectomies. And in those instances, we actually do two different types of mastectomies. There is the traditional mastectomy, which the picture showed, where we take out a lot of skin in the nipple. And the goal with that operation is to make the chest as smooth and flat as possible, so it's not all wrinkly or anything like that. But with reconstruction, we want to leave more skin behind. And so we will do two types of mastectomies, either skin sparing in patients who have to have their nipple removed, either because they're, probably most commonly because the cancer is too close to the nipple, or we'll sometimes do what's called nipple sparing, which is where the entire outer covering of the breast is left behind, including the nipple. And then the breast is removed through relatively small incisions, and we leave the entire outer covering. And so we work with plastic surgeons to do one of those two types of mastectomies when we are doing reconstructive surgery. Now, it's not mandatory to do reconstruction. Reconstruction does nothing to assist in the cure of the breast cancer, but it is completely acceptable and something we provide for the patients who desire it. And so we're happy to do that with our plastic surgery colleagues. Okay, so thank you very much. I appreciate the opportunity to talk, and I'll turn it over to Dr. Joe.
Well, thank you, Dr. Yazdi. That's amazing, your work, and very insightful. So our last speaker tonight is Dr. Vincent Joe, Medical Director for Oncology. Dr. Joe is a board-certified radiation oncologist who has worked in the St. Louis community since 2000. Dr. Joe did his training and education at the University of Rochester in New York, where he was chief resident in 2000. He has worked at MOBAP since 2012 and has been the medical director since 2014. Dr. Joe has multiple publications in his field of expertise. Dr. Joe, tell us about radiation therapy options after breast-conserving surgery.
Thank you very much for the opportunity. Tough to follow Paul and Melissa, but I'll do my best. I'm going to mainly focus on radiation treatment options after breast-conserving surgery because there's actually been a couple of neat breakthroughs in this field in the past few years. So the role of radiation after breast-conserving surgery, Paul basically touched on. And before the 1970s, most people had to have a mastectomy. There really wasn't any choice. There were basically 4 big trials that accrued patients in the 70s and 80s comparing mastectomy versus lumpectomy with radiation. And those were the trials that basically showed fairly equivalent local control with maybe a slight edge to mastectomy, as Paul mentioned. The numbers Paul mentioned about lumpectomy having 6 to 8% local recurrence, those are numbers with radiation. If you did not get radiation and had a lumpectomy by itself, if you looked at all women with breast cancer, your rates are more along the lines of 25% that the cancer will come back. So radiation is very necessary to optimize your chances of keeping this away. Go ahead to the next slide, please. So contraindications to receive radiotherapy after breast conservation include if you've had prior radiation to your chest, if you're pregnant, If you have diffuse microcalcifications, which basically is usually a harbinger for diffuse disease in the breast, then you'd probably be better off with a mastectomy if you had widespread disease. If your tumor's too big and it would lead to a poor-looking breast after a breast-conserving surgery, then we'll usually recommend you just go ahead and have a mastectomy. If you have a connective tissue disease called scleroderma, or if you have active lupus, patients with those diseases tend to have more trouble with radiation with regards to side effects, so we usually avoid radiation in those patients. And if you have a BRCA mutation, especially if you're premenopausal, we will usually push you towards mastectomy given your genetic predisposition to a recurrent cancer in the breast. Go ahead to the next slide, please. So external beam radiation is basically an X-ray treatment. It's the same X-ray like when you get a chest X-ray or a mammogram. The difference is the energy of the X-ray that I use for cancer treatment is about 1,000 times more powerful than what you get with a chest X-ray or a mammogram. And we can focus these X-rays pretty precisely where I need them to go. And for breast cancer, we typically will treat the whole breast. In the old days, back when I was in training in the 90s, we would normally give about 5 to 5.5 weeks to the entire breast. And then we would deliver what we call a boost, where we just focus the radiation just on where the cancer was in the first place, for another about 5 treatments or so. So the average treatment was usually around 33 treatments, basically about 6.5 weeks, Monday through Friday. Each treatment takes about 15 minutes a day. You get the weekends off. More recently, we've been moving to a shorter schedule, basically based on data from Canada and Britain, where they have less radiation machines because of socialized medicine, but they still have a lot of women with breast cancer. So they tried to get their patients through faster by giving them a little higher dose per day and getting them done instead of 5.5 to 6.5 weeks, they get done in 3 to 4 weeks. And basically that data was published, I think, over 20 years ago now, I think. And it showed basically equivalent control rates. So the standard treatment in almost any hospital in the country at this point would be about 3 to 4 weeks of radiation for early stage breast cancer. Obviously, if your nodes are positive, that changes things. If you had positive margins and higher stage, that also changes things. But basically, when you have an early stage breast cancer, the traditional treatment these days is about 4 weeks or 20 visits is the average. Next slide. So like I said, we're doing some newer things now for these early stage breast cancers. So it does behoove you to get your screening annually. So if we do catch something, we catch it early, and it'll give you more options probably. Next slide, please. So why should we change? Like I said, most patients can find 4 to 7 weeks of daily treatment too long. Sometimes they live too far away from a radiation facility. They want to get their treatment done more conveniently, either with a shorter regimen or try to avoid the daily travel of 4 weeks or even 7 weeks of radiation. Also, the vast majority of tumors, if they do come back, tend to come back where they started. So go ahead to the next slide, please. One approach has been in Britain, actually. They've done a lot of work on this. Again, with socialized medicine, they try to push people through a little faster because they don't have as many resources. So they've actually published data on a once-a-week schedule to the whole breast for 5 weeks. So just 5 treatments, once a week for 5 weeks. And they actually have 10-year data on this, showing the local control is just as good as 5 weeks of daily radiation. And the normal tissue long-term cosmesis, or how the breast looks at the end, is fairly similar. So this is one option that we have used for women who qualify for this, and also for especially for women who live really far away, and coming back and forth for 4 weeks is just too much. Next slide, please. Another way we can shorten up treatment is to do what we call partial breast radiation. Basically, we're just focusing the radiation at the tumor bed where the cancer was after Dr. Yazdi cuts it out. And basically, there's a couple ways we can do this. One is called with brachytherapy. Brachy is, I think, the Greek for near. So basically, it's a near, basically delivering radiation right to the tumor bed with either a catheter or a balloon that we put into the breast. And basically, this balloon has an open channel in it that can basically receive a radioactive source that can deliver radiation from the inside. And we do something, offer this option at Missouri Baptist. if you're a candidate for this, my partner, Dr. Dyke, is actually the one who does these procedures. He'll put the catheter or the balloon basically into the tumor bed, and then it stays in the breast, and it has like a little pigtail that comes out, and then we connect the pigtail to a fancy radiation machine that can move radiation, a radioactive source into the balloon and deliver radiation from the inside. And usually each treatment takes about 30 minutes. It's done twice a day, so you have to come in the morning and in the late evening or late afternoon, about 6 hours apart. But it's done in just five days, or basically 1 week. Another option would be now is to do a partial breast radiation, where we do focused external beam radiation, where we use the same X-ray than we were doing for whole breast radiation, but we just focus on where the tumor bed was. And basically, we can do what we call intensity modulated radiation, where we can deliver a very conformal dose just to that tumor bed and do it in 5 treatments these days. It can be done every other day, or it can be done 5 days in a row. So basically 1 to 1.5 weeks. And a lot of good data on this has been published coming out of Europe and Italy. And there's also, I think, some Canadian data out as well coming out that's going to basically show very good results. There was actually a phase 3 trial, which meaning they were comparing patients head to head, getting whole breast radiation versus partial breast radiation. The whole breast radiation arm won, but it was only about 1% difference in local control. So it was superior, but the superiority was just a 1% difference. So I think if you're a good candidate for partial breast, then there's lots of hoops we have to jump through to qualify. But if you do qualify, that is something we can think about for you. And we do offer both options here at MOBAP. So this slide shows you what brachytherapy, or a sort of a balloon treatment. This is a device called Mammosite, which we actually use something a little more complex called a SAVI catheter, which has more than one channel. This balloon just has one channel, but we can deliver a multi-channel radiation brachytherapy treatment, which can basically shape the dose a lot more conformally, and we can sort of cool things off if it's too close to the skin or too close to the chest wall muscles, a lot better than you can with Mammosite. But the Mammosite sort of gives you the idea of what we do. Is basically we'll put a balloon into where the tumor bed is, and then we connect the balloon to basically a fancy machine with a radioactive pellet at the end of a fishing line. And the machine unspools the fishing line, and the pellet swims into the tube, swims into the catheter and into the balloon, and then it sits in there for about 10 to 15 minutes. And when it's done delivering the dose, then the machine will reel the fishing line back in, and then the seed comes out and goes back into the lid box. And then we disconnect the patient, and then they're good until they come back in the afternoon. So this technique, we would do 10 treatments over 5 days, and you'd be done in about a week. Next slide, please. The alternative is to do what we call partial breast external radiation using IMRT, or intensity modulated radiotherapy. And here you can see here's a patient we just treated, I think about 1 or 2 months ago, delivering very focused radiation. You can see the dose cloud basically focused over that one spot, which is where the tumor cavity is. Usually we'll see clips there that Dr. Yazdi is kind enough to leave for me to show me where the tumor was after he cut it out. And then we'll basically focus all the high dose radiation to that area. Each treatment takes about 15, 20 minutes a day. 5 treatments, you'll be done in a week or a week and a half if you do every other day. So a couple ways you can go with that. So which method's the right one? For partial breast radiation, it's definitely a selection process where we kind of cherry pick the best people we think would do well with this and avoid recurrence, which is obviously our top priority. But if you do fit the criteria, it is reasonable to talk about these options, and we do offer all of these options here at Missouri Baptist. And there are many criteria that we can talk about if you have to go through a breast cancer treatment, but we do have many options for you these days. And I think that's it. Next slide should be, yeah, one of my favorite quotes. So we're good.
Well, that's amazing. And I can really hear the personalized medicine coming through from all 3 doctors. But I'm just truly amazed at the knowledge, innovative therapies, and progress in breast cancer care our speakers have presented. And we're so thrilled and grateful that you 3 are part of the MOBAP team. So I just want to remind everyone that coming soon is our next session. And just to remember to sign up at bjc.org. I would like to thank our panel of experts, our Champions for Care Committee for helping to educate the community MOBAP serves, and thank you to all of our participants for joining us tonight. And if you want to consider joining our Champions for Care group, as you can see, there's a great need across Missouri, but our 2021 project is providing screenings, as all three doctors have talked about, as kind of the first step on our MOBAPS mammography van. And the van serves about 3,400 patients a year where they live, where they work, and assists roughly about 1,000 uninsured patients a year in 31 counties in Missouri. So I hope everyone is well, and let's go ahead and get to some of our questions if anyone